So we were talking about central nervous system. Central nervous system is brain and spinal cord. We know that. Brain and spinal cord, what do they do? Yes, it's for higher level thinking. The brain and spinal cord will control the autonomic nervous system, endocrine system, and the nerves project from the brain to supply the organs of the head and neck through the cranial nerves. Spinal cord, it could be a center for the reflex. It is the traveling tracks of the nerve coming from the brain in the spinal cord, and they will leave at the different levels at different regions to become the peripheral nervous system. So brain and spinal cord, I believe, to a good extent, you remember that, and like the coverings of the brain. So when we say brain, our brain, before we can touch the brain, what we have to go through? We have to go through scalp, S-E-C-A-L-P, scalp. P stands for periosteum, S-C-A-L-P, periosteum. Where is it? The white layer, periosteum. And after that, we will have a skull bone, which we call cranium. And after that, we have three layers. They are DAP, dura mater, arachnoid mater, and pia mater. And pia mater is the layer which is stuck to the brain substance. So it will be very difficult to separate pia mater from the brain substance. Dura mater is the closest to the skull bone, and dura mater has two layers. On the bone side, it is called periosteal layer. On the meningeal side, it is called meningeal dura mater. But anyway, let's try to remember as dura mater. Arachnoid mater is in the middle. And you can see the arachnoid mater and the pia mater. In that place, we have the blood vessels. And therefore, a condition called subarachnoid hemorrhage, means that's like an aneurysm in the brain, aneurysm in the blood vessel. They are usually arising from the arteries in the subarachnoid space. And if they rupture, we will get blood in the subarachnoid space. Pia mater, which we cannot easily split them out from the brain substance itself. So remember scalp and meningeal layer, dura mater, arachnoid mater, and pia mater. This is the skull bone. We have lift up the scalp, the skin covering the skull, and now we can see the bone itself. And what do we mean by scalp? Scalp means skin for the head, scalp skin. Subcutaneous tissue, SC stands for cutaneous tissue. A stands for aponeurosis, L stands for loose connective tissue, and P stands for the periosteum. So scalp, after the scalp, you will get to the DAP, dura mater, arachnoid mater, and pia mater. And then this is our brain, like the cranium. I'm not going to skip it, but these are the different parts of the brain. Like if we are looking from the side of the brain, we will have the whole brain, which is what we call cerebrum. Of course, cerebrum includes frontal lobe, parietal lobe, and occipital lobe. Underneath the cerebrum is cerebellum, and the brainstem. If we flip around from inside of the brain, we have an area called diencephalon. Diencephalons include thalamus, hypothalamus, epithalamus. So these are the different parts of the brain: cerebrum, cerebellum, diencephalon, and the brainstem. Brainstem includes midbrain, pons, and medulla oblongata. Midbrain, pons, medulla oblongata. So that's three structures constitute the brain stem. So looking from the brain, from outside, this is cerebrum, cerebellum, and the brainstem. We cannot see the diencephalon, which will be here. And the brain, we will divide into frontal lobe, parietal lobe, and the occipital lobe. And here in the just above the ear region, we have the temporal lobe. So I want you to remember frontal lobe, parietal lobe, occipital lobe, and temporal lobe, which constitute the cerebrum. Yeah, so frontal lobe, parietal lobe, occipital lobe, temporal lobe. So when you study this anatomy, I want you to speak out, like just lose yourself. It's just like try to learn a different language. Might be like Portuguese, Spanish, French, Latin, Greek. So that sort of language. So we have to speak out. Only then these names we are used to talking about the names. So frontal lobe, parietal lobe, occipital lobe, and temporal lobe. Temporal lobe is in the temporal region. And I believe you remember the temporal bone, petrous temporal bone, squamous temporal bone, and the muscle on top, which is called temporalis muscle. So now we are looking at the brain from the side outside. And this is the brainstem. And we have like the whole brain has right half and left half. And this is anterior, this is posterior, then this is the right cerebrum hemisphere, and this is the left cerebrum hemisphere. So now we are looking at this brain from outside here, from outside. This is the surface we are seeing. So now we will look at the brain, this right side of the brain in the medial portion. And this is what we see. So again, like we have frontal lobe, parietal lobe, and occipital lobe. And now we have to split the cerebellum. Cerebellum is only one structure. It is not like cerebrum, which has got right and left hemisphere. Cerebellum is like one big structure. Now we are splitting the cerebellum into half. And this is what we see. Like it is very much like cauliflower shape. And I want you to see the brainstem. Brainstem is here, medulla oblongata, pons, and midbrain. Midbrain, pons, medulla oblongata constitute the brainstem. So that the texture you look is different here. And when diencephalon is the area here, which is made of thalamus, epithalamus, hypothalamus. So thalamus, hypothalamus, epithalamus, that's contribute the diencephalon. And what I want you to remember is corpus callosum. Look at the corpus callosum, which is slightly different from the other type of brain substances. It looks like more like the quality, the texture of the brainstem is similar to texture of the corpus callosum. Corpus callosum is something connecting the right hemisphere and left hemisphere of the brain. Yeah, so just underneath the corpus callosum, we will have the lateral ventricles here, and in front of the fourth ventricle, we will have the fourth ventricle in front of the cerebellum, and third ventricle will be somewhere around here. So, it is, do you really have to know everything in detail? No, but I think it's good to know, and especially if you're going to use anatomy as your foundation for future career, like nursing, like medicine, like physical therapy. So you need to know these, at least which is where and what. If someone is talking, you need to know what they are talking about. So that's the corpus callosum, which connects the right hemisphere and the left hemisphere. And once we pass, this brainstem pass through the foramen magnum, then it is called the spinal cord. So spinal cord just underneath the foramen magnum, and it is in the cervical region, cervical spinal nerve will come out. In the thoracic region, thoracic spinal nerve will come out right and left. In the lumbar region, lumbar spinal nerve will come out. And at the level of lumbar 1 and 2, let's say lumbar 1 intervertebral disc, so which is the disc in between the first and second lumbar vertebra, the spinal cord ends. It ends because it is still a big, thick, solid structure. So it ends in a multiple fiber, group of multiple fiber, which looks like a tail of a horse tail, and therefore we will call it cauda equina, which is the end of the spinal cord. So this one big block of the nerve just spread into multiple fibers, and like, you know, they will just spread everywhere and they will go. And that's the way the nerve leaves the spinal cord. Like the fourth nerve will leave underneath the pedicle of fourth lumbar vertebra. Third nerve will leave at underneath the level of third lumbar vertebra, and so on. So how did it start? It starts from the very early stage. Like, you know, in the cervical region, we have 7 cervical vertebrae, C1, 2, 3, 4, 5, 6, 7, and this becomes thoracic 1 vertebra. So in the cervical region, cervical nerve root lives above the pedicle or body of the cervical 1 vertebra. At the C2 live above the level of the cervical 2 vertebra, and so on. And at the level of C7 nerve root will live above the level of the C7 vertebra or the pedicle. But we have one extra here, C8. We only have 7 pairs of spinal nerve root from the cranium cervical region, but we only have 7 cervical vertebrae, but we have 8 spinal nerve roots. So therefore, cervical 8 nerve root we have to leave below the level of the C7 vertebra. And from then, you know, all the nerve roots will come underneath the level of the named vertebral body or the pedicle. So now here we come, like starting from T1 spinal nerve root will live underneath the T1, T2 will live underneath the T2, and so on and on and on. But it is just because of we only have 7 vertebral body in the cervical spine, but we have 8 spinal nerve roots in the cervical spine. So I hope you remember this concept. With time, if you forget, that's not a big deal, but at least you can easily come back and visit this knowledge. So this is the MRI scan, which stands for magnetic resonance imaging. So when you look at a MRI scan of the spine, it's not a big deal. Take a deep breath in and try to look at the white cerebrospinal fluid, CSF. So this is the spinal cord, which is the black color. Around the spinal cord, we have the cerebrospinal fluid, which is white color. Then if you see that this is T2, so T2 images, thorax, T2 CSF white. So CSF is white here. If you look at here, CSF, well, you know, it's dark here. So T2 CSF white, T2 weighted MRI scan. That is the easiest way to start. Again, don't get excited. Just keep calm down and then look at the bones here. The bones here, square block. The bone here, square block, square block, square block, square blocks. And they are like a smooth line running here, smooth line running here. And you can see the disc, which is filled with water. Therefore, they are white. Good disc height, good disc height, good disc height, on and on and on. So which means this is a very healthy spine. Now, if you look at this, there is a step here And the disc here, we have lost the disc here. So between the lumbar 5 and sacrum 1, we have lost this as lumbar 5 L5S1 disc is damaged and degenerative already because of the degeneration. The spine is one is moving forward, one is moving backward. And if the patient say pain here, that fits with what we see on the MRI scan. So that's the way, we look at the MRI scan. Of course, the more you grow up, the more you will have to learn in detail. But whenever you see a MRI scan or the plain radiograph, I want you to keep calm and then just try to solve one after another. So this, if you look at that, this is the vertebra body. So this is lumbar 1, 2, 3, 4, 5, sacrum, and the transverse processes. There will be lamina and pedicle and lamina. If you look at that, the L1 nerve root will live underneath the pedicle of the L1 vertebra. So that's really important. Like it's changed from the cervical 7 nerve root because we only have 7 cervical vertebra. So when the nerve root leaves the spinal cord, so if we remove all the bones, and this is the spinal cord, and the nerve roots coming in to the spinal cord and leaving out of the spinal cord. And the combination of the leaving roots and the going in roots, which is called the spinal nerve. So let's look at the spinal cord. You can see the H structure here, which is darker color. That is what we call gray matter of the spinal cord. The outer layer, which is whiter, is called white matter. Look at the here, little dot here, which is the central canal. We will have cerebrospinal fluid inside the spinal canal, as well as look at that, the outer coverings here, outer coverings of the spinal cord, which is the extension of the meninges, which is called the dura mater, arachnoid mater, and pia mater. All these 3 structures follow the spinal cord, and they even try to follow the spinal nerve roots. You look at that, these spinal nerve roots, these outcovering of the spinal cord, they are following with the spinal nerve. And I want you to take this image. Like when they leave, these nerve roots leave the spinal cord, they are not just one and big in and out. They are small, multiple, which is called rootlets. So the whole combination is called anterior root, and the whole combination is called posterior root. But here, anterior root and posterior root, but they finally divide into multiple small fibers, or they originate from multiple small fibers, which is what we call the rootlets. So this is a really lovely diagram which try to explain the spinal cord and the rootlets coming out from the spinal cord. They finally merge to become the rootlets, and then the anterior and posterior roots will combine to form the spinal nerve. So this is the way they are coming out. You can see the spinal cord here with the H gray matter and the anterior root and posterior root. Posterior root has dorsal root ganglion, and when they come out, they become a one combined spinal nerve. And the spinal cord will be inside the spinal canal, which will be covered with the dura mater, arachnoid mater, and pia mater. Where do we have our CSF? CSF will be underneath the arachnoid space, subarachnoid space, subarachnoid space in between the arachnoid and the pia mater. That's where so I hope you have seen or you have heard about the lumbar puncture. Lumbar puncture means just prick a needle into the lumbar spine to get the cerebrospinal fluid. So this needle need to go underneath the subarachnoid space to take the cerebrospinal fluid out to check for analysis. So yes, all these nerve coming out, and then some of the nerve roots, they will merge together to form a big nerve. So let's say, for example, sciatic nerve is a combination of tibial nerve and the common peroneal nerve. This book keep writing fibular nerve. I keep saying peroneal nerve. They mean the same, common fibula or common peroneal nerve. So the tibial nerve origin is color-coded with the orange. So lumbar 4 to sacrum 3. So all these spinal nerve roots combine together to become the tibial nerve portion, and the upper 4 combine together, nerve roots will combine together to form the common peroneal nerve portion. But combination of this tibial portion and fibular portion, it is called the sciatic nerve. So this is the big sciatic nerve which you have, and we all have this sciatic nerve coming from the back of the sacrum and then running along the back of our thigh. And now finally it will split into common peroneal nerve and the tibial nerve. Tibial nerve will go just posterior to the median malleolus, and the common peroneal nerve will come into the anterior compartment. So yes, sciatic nerve is the longest nerve in our body, and it is the biggest nerve. So if one damage this nerve, it is a big thing because they will damage the movements and sensation of the leg, which is a big deal. And this is the nerve. Let's say we know that we have neuron and axon. Axon will be covered with the myelin sheath. This axon and myelin sheath will be covered with the endoneurium. Endoneurium, multiple endoneurium covered axons, they are packed, and then they will be covered with the perineurium. Multiple perineurium covered group of nerve fibers, they are called fascicles. Multiple fascicle will be covered with the epineurium. That is what we call nerve. So when you say the ulnar nerve, the radial nerve, or sciatic nerve, it is composed of these structures. So inside the blood vessels, here inside the epineurium, but outside the perineurium. As I always say, does it really important for you? Not at this stage, I mean, not even when you become a nursing student, but they might teach you again the same principle. So if you take the principle, then it will be easier when you go to the next stage. And this is the way we develop our brain and spinal cord. And as you remember, neural tube. So the question is, what is the embryonic structure our brain and spinal cord develop? Of course, they develop from neural tube. Neural tube will gradually expand here and there, and then finally become brain and spinal cord. That's it. So, and now we are looking at the coronal section of the brain. We see the gray matter and white matter. This is the cerebrum. Now we can see the cat section, lateral ventricle. Look at the shape of the lateral ventricle. We have the right lateral ventricle. We have left lateral ventricle. We only have 1/3 ventricle in the center, and we only have 1/4 ventricle in the center. But lateral ventricles, we do have it on the right side and the left side. And then finally, they come down into the brain and brainstem. Yeah, brain. What is the difference between gray matter and white matter? Gray matter is mainly composed of neurons and cell bodies. White matter is axons, non-myelinated axons. Of course, both white matter and gray matter, we will have neuroglial cells, because neuroglial cells are supporting cells. Neuroglial cells like astrocytoma, astrocytes will support the neuron, we feed the neurons, we give nutrition, we maintain the internal milieu, internal environment of the brain and neurons. So therefore, we need the neuroglial cells because these are supporting cells for the neurons. And of course, you know, in the gray matter, we have like the neuronal cells, we have dendrites because neurons, we have dendrites, axon terminals, and neuroglial cells. So the difference between gray and white matter is gray matter neuro, white matter non-myelinated axons. If you try to remember that will make our life a lot more easier. Look at the brain from the side, and this is the MRI scan. So if I show you this MRI scan, I believe it might be too easy for you. Why? Because you know that this cauliflower inside the brain is the cerebellum. You can see the big bump and oblongated structure, and this little one is midbrain, pons, and medulla oblongata. You know that. And this is corpus callosum, which is too easy for you guys. And underneath the corpus callosum, we have the lateral ventricle. This is the diencephalon area, which is made of hypothalamus, epithalamus region. You can see the occipital lobe here. You can see the frontal lobe here, and the parietal lobe will be somewhere around here. So that's too easy. That's too easy for you guys. And this is what we see. Yeah. So that's what is a big deal between the MRI scan and the normal anatomy for anatomy students. So that's the way we have to try to relate. Otherwise, you know, our anatomy knowledge will not be able to imply on the clinical knowledge. So if you know this, I believe you know that. That's simple. So what about this? Looking at the brain from the front coronal section, and at this region, we can see the two lateral ventricle, right lateral ventricle and left lateral ventricle. And you can see a small little one here, third ventricle. And you can see the slightly bigger one, which is the fourth ventricle. So if you see that, and this one, the same, yeah. But of course, in this section, depending on how anterior or how posterior you go. So if you want to see the third ventricle and fourth ventricle, you might have to make a section, make a cut in this region. So at the very front, you are not going to see anything apart from the frontal lobe. And then gradually, if you go posterior, you start seeing the anterior horns of the lateral ventricles. And if you want to see this region, like both lateral ventricle, third ventricle, and fourth ventricle, then you might have to make the cut of the coronal section, might be somewhere around here. Hey, what is the big deal between this and that one? Yeah, so the same. And this is the axial section. This is the axial section, and this is the right side of the brain. So the person is lying flat, and this is the right side, this is the left side. This is the anterior frontal lobe, this is the posterior occipital lobe. And look at the lateral ventricle if we make a cut in this view. So it is slightly different, isn't it? So now so what are we doing with that? So we are doing this view, but cutting in a different level. Why do we get this shape of the lateral ventricle? Because this is anterior horn of the right lateral ventricle. This is the anterior horn of the left lateral ventricle. There here as well, we have the posterior horn of the lateral ventricle, posterior horn of the lateral ventricle. So we need to know the anatomy, the shape of the lateral ventricle. Hey, the shape of lateral ventricle is very awkward shape, you know. It comes to the front as anterior horn.
Salina Community College.
Oh, just 1 minute, please. Hello. Sorry, guys, that's from the college. So look at the shape of the lateral ventricle. We have the right lateral ventricle, we have the left lateral ventricle, and lateral ventricles have anterior horn here, and posterior horn here, and inferior horn here. So 3 horns coming like that shape is, it is, I don't know why we have this shape of lateral ventricles, but at least we have right lateral ventricle and left lateral ventricle. Combination here, they will form the third ventricle. And the exit from the lateral ventricle into the third ventricle, it is called interventricular foramen. Inter, in between right and left ventricle, interventricular foramen. And now we get into this slight dilatation, which we call third ventricle. From third ventricle, it will go into the fourth ventricle via the cerebral aqueduct. So cerebral aqueduct. So we only have one third ventricle. We only have one fourth ventricle. We have the right and left lateral ventricles. So that's if this is the anterior or coronal view, this is the lateral view or sagittal view. I want you to appreciate where the third ventricle is and fourth ventricle is, and this is the lateral ventricle. So we have some sort of fluid inside our brain, which is carefully structured. And the blood supply to the brain, as you know, from the common carotid artery, which divides into internecrotic and externecrotic artery. Internecrotic for the inside of the brain, yeah. Internecrotic is inside of the brain, and I want you to, at least some working knowledge about this cycle of Lewis. Cycle of Lewis, and I hope you remember that cycle of Lewis. It is, you won't be able to remember like within 1 second. I mean, you might have to look at that again like 2-3 times. For me, I have to read 10 times and I still cannot remember. So not to worry too much, but the artery which is lying on the pons, which we call it basilar artery. So basilar artery is the combination of right and left vertebral arteries. Vertebral artery arises from the subclavian artery. So right subclavian and left subclavian will give a branch called vertebral artery. Right vertebra and left vertebra will come into basilar artery, which is running on top of the brain. So what I want you to appreciate is if something goes wrong with this vertebral artery or basilar artery, that will damage the brain stem. So the brainstem damage is not good because we have vital centers in the brainstem. What do we have? We have the cardio and respiratory centers. They are all in the midbrain pons and medulla oblongata. If there is any hemorrhage in the brainstem, it is near equal death. So the brainstem arterial damage is not good. And this is for the basilar artery, which will split into right and left posterior cerebral artery. And the internecrotic artery will give a branch and call the anterior cerebral artery, and the main branch will continue as middle cerebral artery. So these arteries, they will communicate with each other. So in between two anterior cerebral artery, we have what we call the anterior communicating artery. Here at the back, we call it posterior communicating artery. Here, posterior communicating artery. When trying to connect to each other, now we have a ring of the blood supply, which we call cycle of Lewis. Cycle of Lewis is important. Cycle of Lewis is important, because if there is a blockage here, the blood will be diverted from the other side. So which just try to redistribute the blood flow, which is really important. And this is the motor representation and sensory representation. So the area of the brain, which is occupied in the motor cortex and sensory cortex by different part of the body. So if you look at that, our hand, like this small hand, occupying a large portion of the brain, and therefore we can do a lot of fine movements. So the hand is richly supplied with multiple nerve fibers and richly controlled from the cerebral cortex. Therefore, this hand can do multiple things, a lot of things we can do. And look at the face here. If you look at our lower limb, like which is the hip, knee, leg, it is, you can't do much. So that is pretty obvious here. That is pretty obvious here. Therefore, we are pretty, apart from walking and running, we cannot really twist with our feet or the leg. But when it comes to the sensation, our feet sensation area in the brain is pretty big. Therefore, the feet is pretty prickly because it has a large sensory cortex area representation. Of course, our face and hand is the biggest. So this is in the motor cortex. This is in the sensory cortex. Motor cortex is more anterior and sensory cortex is more posterior. Yeah. So we have both motor cortex on the right and left, and we have both sensory cortex on the right and left. And all these neurons from the brain, gray matter, look at it, they are all originating from the gray matter. They will all march together. Look at the way it has to come down, like, like a radiation, and therefore we will call it corona radiata. Look at that, and it is going in between this nucleus, which is the darker color, and this nuclear thalamus, and therefore we will call this area internal capsule. Look at that internal capsule, internal in between. So internal capsule is also, if you look at that carefully, all the sensory or motor, all these fibers are packed in the internal capsule. And therefore, if there is any damage, like if there is any blood vessel problem, bleeding or blockage of the artery, which is giving to the area of internal capsule, just small area damage, but it has massive effect here. So because it is contributing it is carrying the whole fibers from the cerebral cortex. So it is a narrow pathway where the brain or originating neurons are leaving the brain. And if we damage that narrow lane, everything will be blocked. And we will have like right-sided or fully left-sided hemiparesis. So these, like, the whole side, unilateral, like arm and leg involvement, for example, like stroke, which damage the whole, like right side, the whole left side, then that's usually damage this area, internal capsule, usually, but not always, but of course here as well, like when they come to the brainstem, yeah, you can damage the heart as well. But if you damage the brainstem, it is even worse because the whole part of the body has been damaged, as well as the cardio and respiratory centers will get damaged. So that's the way we have to differentiate where is the likely underlying pathology, where is the likely underlying damage when we see a patient with stroke. So let's move on. And then this is the cycle of Willis. We move on. And now the way the blood coming back from our brain. So you can see that from the brain substance, these little veins will go into the large veins here, which is in the center. So the large venous sinuses, they are in between the periosteum layer and the meningeum layer of the dura mater. Yeah, you remember that? The very first picture we saw. So dura mater has two layers. Dura mater in some part of the body split into two, outer close to the bone periosteal layer and inner close to the other meninges, which is called meningeal layer. These splitting of the dura mater will create venous sinuses, and there are multiple venous sinuses in our body, which we will study a little bit in the later diagrams. But now I want you to appreciate all the venous return from the brain will drain into the venous sinuses. So this is in the sagittal plane here, which is in the midline sagittal plane. Therefore, we'll call it superior sagittal venous sinus. If we have superior sagittal venous sinus, we will have inferior sagittal venous sinus. Okay, let's forget about that. So all the blood returned from the brain will drain into the venous sinuses. Venous sinuses are made of the dura mater, periosteal layer, and dura mater, meningeal layer. So these two split open, and that will contain vein, and into these veins we will drain the blood returned from the brain substance. And look at the CSF, which is color with the light blue color here, light blue color. Now here you can see the corpus callosum. Yeah, corpus callosum. Don't forget the corpus callosum. The corpus callosum might not be that important, but of course it's important because it is connecting the right brain and the left brain. But it is a good landmark to start seeing things. So this is the corpus callosum. Underneath the corpus callosum, we will have the lateral ventricle. Look at that. These ependymal cells, which is color with the red color, they will produce cerebrospinal fluid. So this red color cells, they are the ependymal cell, which makes the choroid plexus. So the choroid plexus, which is made of ependymal cells, will secrete CSF. CSF will start from the lateral ventricle through the interventricular foramen, interventricular, in between the ventricles, which is right ventricle and left ventricle, interventricular foramen, they will drain into the third ventricle. And from the third ventricle through the cerebral aqueduct, it will drain into the fourth ventricle, which is just anterior to the cauliflower-shaped cerebellum. And finally, it will go everywhere. Like it will go into the central canal. It will go out of the spinal cord, just inside the arachnoid space, subarachnoid space, and then that will just circulate all around the body. So let's keep going back to the venous return from the brain substance. So the brain substance is here. The venous return will go into the venous sinuses. Yeah. So now at least we know the superior sagittal sinus. Sagittal means in the midbrain. So which is this superior sagittal sinus will be in the midbrain, in the middle of the brain, and which is here, superior sagittal sinus. It is running from anterior to posterior. Look at this. So, and finally, we have multiple venous sinuses in our body. And finally, all the venous sinuses will drain into the sinus called sigmoid sinus. So sigmoid sinus, this is the final destination of all the venous sinuses in the cranium. And sigmoid sinus, once it goes through the foramen magnum, I hope you remember jugular foramen. So I hope you remember jugular foramen. So once the sigmoid sinus go through the jugular foramen, it is called internal jugular veins. So the blood return from the brain is finally will come into the sigmoid sinus, and the sigmoid sinus will be called internal jugular vein once it passed through the jugular foramen. Yeah. So as a reminder, I hope you remember this slide, which we have talked about again and again. It is in your exam, it was in your homework, and you see this anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. Posterior fossa has like a big central foramen, which is called the foramen magnum, which is the inlet and exit of the spinal cord. The brainstem becomes spinal cord when it's go through the foramen magnum. And in the posterior cranial fossa, we have here jugular foramen. Jugular foramen, the sigmoid sinus go through the jugular foramen, and once it's go through and outside the cranium, it becomes the internal jugular vein. That's why we call jugular foramen. And I hope you remember the pituitary fossa here. And here we call it the lacerated hole, which is called foramen lacerum, oval hole, which we call foramen ovale, and small little tiny pointing hole, which is called the foramen spinosum. This is the middle cranial fossa. And so now we can appreciate this jugular foramen is in the one of the contents of the posterior cranial fossa. So yes, look at that. You know, one, if you don't know something, just try to find, is there anything you know? Of course, you know, you have seen superior sagittal sinus. So superior sagittal sinus is running from the forehead in the midline, sagittal plane, forehead coming here, posteriorly here. So that is a superior sagittal sinus. And now if we know the superior sagittal sinus, we know the inferior sagittal sinus. So this is smaller one, inferior sagittal sinus. And look at the cavernous sinus. So cavernous sinus, venous sinus is here, which is, look at that cavernous sinus here. Where is it? It is very close to the pituitary gland. Look at that cavernous sinus, which is where the sella turcica is, cavernous sinus. And as I say, finally, they will all march together. And this margin of the sinuses is called confluence of sinuses. So things are a bit easy, guys, easy. And finally, this confluence of sinus will turn like an S shape, which we call it sigmoid sinus. So start from the superior sagittal sinus, which is in the sagittal plane, which is running from the forehead anteriorly, which is running to the back, occipital lobe posteriorly. And now if we have superior sagittal sinus, we have the inferior sagittal sinus. And finally, and you remember the cavernous sinus, which is very close to the pituitary gland. And look at the inferior sagittal sinus will become straight. It is called straight sinus. Finally, all the venous sinuses join together, which is what we call confluence of sinuses. And this confluence of sinuses will gradually twist and turn to become like an S shape, and therefore we call it sigmoid sinus. And there is another sinus called transverse sinus. Too many names, let's forget about that. But sigmoid sinus will go through the jugular foramen, and now it is called internal jugular vein. So that is not a very difficult thing. I know we will forget all the names in a day or two, but you know, I hope this will give you some foundation when you go to next stage. Like it might be a bit easier if you come back and visit this page again. So superior sagittal sinus, inferior sagittal sinus becomes straight, therefore it is called straight sinus. And around the pituitary, we have the cavernous sinus. Cavern means like a cavity, you know, like a lot of things going on. Cavernous sinus, sigmoid sinus, forget about the transverse sinus, sigmoid sinus, go through the jugular foramen. It is called jugular vein. So what a wonderful structure we have, you know, in our head. So yes, you know, this is a little bit of different image. I will not use this image for the exam, but at least I have I want to say, you have seen this. It's not a very meaningful diagram. So venous sinuses of the brain, and they lie in between the two layers of the dura mater, which is on the bone side, periostea, and on the other dura mater side, meningia. So meningia, in between meningia and periostea dura mater, we have the venous sinuses, and they are straight sinus, superior and inferior sagittal sinus. Occipital sinus, confluence of sinuses. Superior petrosal, inferior petrosal, we didn't see that. Transverse sinus, we saw that, and finally became sigmoid sinus. So you try to forget what is not really important, and you just try to pick a few little things. And then finally, we also have cavernous sinus, phenoporoidal sinus, sphenoid bone, parietal bones, phenoporoidal sinuses. Not very important, but at least I want you to say, hey, I have heard of this name. And now that is here. So this is the sagittal view of the venous sinuses, and this is the coronal view of the venous sinuses. Look at that. This is in the midline, and therefore it is called, the upper one is a superior sagittal sinus. This is what we are seeing in the coronal view here, superior sagittal sinus, and they split into two transverse sinus and inferior sagittal sinus. And finally they will become, what do you call that, sigmoid sinus, because sigmoid S-shaped sinus twists and turn. Therefore, we call sigmoid sinus through the foramen, jugular foramen, that will become the what do you call that, internal jugular vein. So internal jugular vein is just a continuation of sigmoid sinus. And this is a reminder of the ventricles, which is going here and there. And let's look at the ventricle. I hope you remember this. The shape of the lateral ventricle is like pointing to the front, pointing to the back, pointing to the front, pointing to the back, and pointing downwards as well. Anterior, posterior, and the inferior horns of the right and left lateral ventricles. So ventricles are lined by the ependymus, which we call choroid plexus, filled with the cerebrospinal fluid. We have two lateral ventricles. We have only one third ventricle, only one fourth ventricle, and fourth ventricle we open into the subarachnoid space, where the cerebrospinal fluid will circulate around the brain and the spinal cord. So they are all continuous. So cerebrospinal fluid. So I hope you will have to study what is cerebrospinal fluid in physiology. So cerebrospinal fluid, where do we have it? In the ventricles of the brains, lateral, third, and fourth ventricle. In the subarachnoid space, which is just outside the brain, underneath the arachnoid, outside the pia mater. The brain, which is closely covered with the pia mater, and outside the pia mater, we will have arachnoid. In between the pia mater and arachnoid, we have a space called subarachnoid underneath the subarachnoid. So what is cerebrospinal fluid? What is a big deal about this fluid? It's just like our synovial fluid inside the knee joint. Hey, it is not a big deal. It is similar to plasma, but it contains more sodium and it contains less protein. In the whole body, we only have 100 to 160 ml of CSF fluid. So it is very tiny amount of CSF fluid. So when we are seeing the big cavities here, like lateral ventricle, third ventricle, fourth ventricle, and the central canal and the subarachnoid space, don't expect too much. We only have, let's say, 100 to 150 ml of cerebrospinal fluid. Is it important? Yes, it does, because it gives some buoyancy for the brain. It cushion, like water cushion, so that the brain is protected. it has got some nutrients and it carries some of the waste products from the brain, and it will carry chemicals. So in general, cerebrospinal fluid contain chemicals and nutrients and waste products. That's the chemical job, and mechanical job is for cushion and buoyancy. So the cerebrospinal fluid has two jobs, mechanical job and chemical job. Mechanical job is for cushion and buoyancy of the brain and spinal cord. The chemical job is to carry waste and dirty or nutrition or any hormones. So that is the job of the cerebrospinal fluid. Hey, we talk about Monroe Kelly Dockwright. Monroe Kelly Dockwright. Alexander Monroe, who is he? Alexander Monroe is the Scottish physician. Look at that, Scottish physician who start talking about Monroe Kelly Dockwright. So Monroe Kelly Dockwright, what does it say? Like, inside the cranium, our cranium is a rigid box, and we have the brain substance, we have the central cerebrospinal fluid, we have the arterial blood, and we have the venous blood. So anything in and out need to be constant. Therefore, the brain is as we are. So let's say if we have more amount of venous blood, or if we have more amount of arterial blood, or if we have more CSF, or if we have extra brain substance, like for example, brain tumor, it is a rigid box and the pressure inside the brain will increase. We cannot take it. We will present as headache. So if any volume is big, we have to pour it out. So let's say if the venous blood cannot drain out of the cranium, then we will have increased pressure inside the brain, and something will have to come out from the brain. So like it is a rigid box, Monroe Kelly Dockwright, they state that the sum of the volume, brain, spinal cord, blood is constant, and increase in one should cause a reciprocal decrease in either or both of the remaining two. So that is the Monroe Kelly Dockwright. So Monroe Kelly Dockwright state that the intracranial volume is constant, the brain is a rigid box, we cannot carry anything more extra. So I am going to stop here. Well, yeah, 58. So I'm going to stop here for like 15 minutes. I want you to go away. I want you to have a fresh air. I want you to come back 11:15. We will. So now we know what Monroe Kelly Dockwright is. Dockwright said, let's say if there is anything extra other than blood, brain, or the CSF, something will give way. So let's say if there is bleeding inside the brain, then we will have extra blood here, and we have to remove the cranium to ease the pressure inside. Because we are now having extra blood inside the brain, and if we don't move the cranium, the brain substance will come out through the foramen magnum, and that will damage the brainstem, and that will be death. So therefore, like, if we have to ease because of the increased amount of blood, and there will be increase in pressure inside the cranium, and if we want to ease it, we have to remove the portion of the skull bone, so that the brain no longer a rigid box. So that is what we call craniotomy. Craniotomy, opening the cranium, craniotomy. So like otherwise, at the beginning, the patient will present with the headache. So headache is a very common presentation. We all have headache in our life. One or twice, or might be like, like frequent headache, like 2-3 times, 4-5 times a year. Headache is a very common presentation, but the possible causes behind headaches is a lot and lots and lots, and therefore it is got to be cautious. Don't worry too much, but you got to be cautious, especially if other physical signs are present, like the headache, and if one cannot use the arm, that means that there must be a brain tumor, because the brain tumor is present on the brain, and therefore the patient cannot move the arm or the leg, and the patient has headache because it has got extra content in the cranium already. So this is all about Monro-Kelly doctrine. Monro-Kelly doctrine, any increase in one should cause a reciprocal decrease in either one or both of the two remaining two. So we talk about brainstem, which is made of midbrain pons and medulla oblongata. Oblongata is the oblong shape. The brainstem is, when we draw the diagram, it looks a lot, but it looks big, but it is not much. It is only 1 inch to the 2.5% of the brain mass. The brainstem is above the foramen magnum. So foramen magnum is in the posterior cranial fossa, and therefore the brainstem must be in the posterior cranial fossa. So this is a very simple little things which we don't even need to remember. Brainstem function, what does it do? The brainstem, as we know, the passage of nerve fibers from the brain through the brainstem into the spinal cord and leave at many different levels like cervical, thoracic, lumbar, sacral region. So it is a passageway for fiber tracks coming from the cerebrum or coming a spinal cord. The brainstem, from the brainstem, midbrain pons, medulla oblongata, our 12 pair of cranial nerves, like 10 of the 12 pairs of cranial nerve 3 to cranial nerve 12, which is 10, right 10, left 10 pairs of cranial nerve originate from the brainstem. And we have the cardiac and respiratory centers. They are in the brainstem as well. Hey, therefore, the brainstem is really, really important. If the brainstem is damaged, we can damage the cardiac center, and then our heart rate will be everywhere. If we have damaged the brainstem, we can damage the respiratory center, and the breathing might not be normal, right? Like you are struggling with the patient, especially if you see those patients, brainstem hemorrhage, brainstem stroke. I mean, you will see these patients on the ward and have a look. These patients, their respiration or their heart beating is going pretty bad. And if there is a problem, they can damage the cranial nerve 3, 4, 5, 6, 7, 8, 9, 10. And of course, because it is the passageway from the brain down to the spinal cord and then peripheral nerves. So the peripheral nerves will get damaged because if we have the brainstem damage as well. So brainstem is important. It is made of the midbrain, pons, and medulla oblongata. Look at the shape. Look at the shape. Each and every book will describe the brainstem as in this shape. So look at here, pons is a horizontal stripes. Midbrain, longitudinal stripes. And medulla oblongata, you have like central bulge and lateral bulge. Central bulge is called pyramid, and lateral bulge is called olive. Where is olive? So olive, okay, it's not drawn here. Here, olive. So olive here. So this is the lateral bulge, which is called olive, and central bulge is called the pyramids. So again, you don't really need to remember pyramid, olive, but if someone say olive and pyramids in the brainstem, I want you to know where they are. And the origins of the cranial nerves, look at that. third cranial nerve, oculomotor nerve number 3, which is at the junction of the midbrain and pons. Fourth cranial nerve, which is at the junction of midbrains and pons. So 3, 4 between midbrain and pons junction. And then look at this big nerve, trigeminal nerve, 5 here. 6, 7, 8. Look at the 6, abducens nerve, cranial nerve, which is at the junction of pons and medulla oblongata. 6, 7, 7 cranial nerve, pons and medulla oblongata. And 8, vestibulocochlear nerve here, so very close to the facial nerve. So 6, 7, 8 at the junction, and 9, 10, 11, 12. 9, 10, 11, 12. It is originating from the midbrain. So that is the arrangement of the cranial nerves coming out from the brainstem. Arrangement of the cranial nerves coming out from the brainstem. And look at the pituitary gland here. This is what we know, which is in the sella desica region. The cross section, if you get the midbrain here, this is midbrain, pons, look at the shape, pons, bulge, central bulge, only one central bulge, and medulla oblongata, we can see the pyramids and olive. Yeah, pyramids and olive. So these are becoming like not important, it's just for the information. Red nucleus, look at that, red nucleus is in the midbrain, which is like a trouser, boy's trouser, boy's short pant. Yeah, midbrain looks like a boy's short pant. Pons, little bulge, central bulge, and medulla oblongata, 2 bulge. So let's go and read a little bit. It's GS. So substantia nigra, nigra means black, substantia, substance, black substance here. Hey, if we have something dark color, it might be made of multiple neurons, isn't it? So, and the red nucleus, look at the red nucleus. So that is in the midbrain. So pyramidal tracts, superior cerebellar peduncle, substantia nigra, red nucleus. So motor flexion. So pons, we know that at the back of the pons, we have the cerebellum. In front of the cerebellum and back posterior to the pons, we will have the fourth ventricle. Yeah, it's easy. For the rest, we forget that. So pontine nuclei, cerebellum, in contact with the middle cerebellar peduncle, in continuity with the cerebellum, we have reticular formation. So this is important, reticular formation. So which is important for the sleep and wake pattern, reticular formation. So this reticular formation is in the pons. Therefore, if there is damage to the pons, this reticular information system can get damaged. And medulla oblongata, we try to remember as the 2 bulge on each side. So pyramids and olive, yeah, pyramids and olive. So medulla oblongata, pyramids and olive. So pyramids, olive, and pyramidal tracts. Pyramids, where the motor fibers coming from the brain, going through the brainstem, the motor fibers, they are in the pyramids region. So pyramid is made of motor and olive is made of sensory fibers. So motor fibers coming down from the brain, and in the pyramid region, these motor fibers are bulky, therefore they form pyramids. And the olive is on the lateral side, it is in the sensory, for the sensory nuclei to the cerebellum. nucleus fasciculatus, nucleus cuneatus. So these names, yes, for completeness, touch, pressure, joint position, proprioception. So just remember that. And now we will move on. Reticular formation, that is important, guys. Reticular formation, which is important for the cardiac center, respiratory center, vasomotor center. Vasomotor center means like blood vessel dilate or constrict depending on the situation, like reflex. And these are situated in the medulla. So that's why medulla is important, because we have respiratory center, cardiac center, vasomotor center. And now we will look at the cross section, coronal section, looking at the brain from the front, and we can see the lateral ventricle, we can see the third ventricle, we can see the fourth ventricle. Yeah, so this is easy. We can see the fourth ventricle, we can see the fourth ventricle, we can see the third ventricle, we can see the lateral ventricle, which is in the coronal section. This is the right hemisphere, this is the left hemisphere, this is the cerebellum. We have the brainstem here. So if we change this photograph into this diagram, all the nerve fibers from the brain, like from the motor cortex, sensory cortex, we have to come in between the narrow area, which is what we call internal capsule. And as you can see here, internal capsule is packed with multiple nerve fibers, and therefore damage to the internal capsule is really, really damaging. And like, you know, all these from the fibers from the right, fibers from the left, at the medulla oblongata, they will decussate, like 80% will cross to the opposite, 20% will run in the same direction. The same thing, like right cross to the left, left cross to the right, 80% cross, 80%, roughly 80% cross, 80% do not cross. And now you can see the green color, which is called the corpus callosum, the green color corpus callosum, which is connecting the right side of the brain and left side of the brain. And underneath the corpus callosum, we have the lateral ventricle. So this diagram is really, really lovely, guys. And you can see the third ventricle, you can see the fourth ventricle here. So this is a really lovely diagram. Cerebellum. Cerebellum is for the balance. Let's try to remember that cerebellum is involved in the balance. So if there is damage to the cerebellum, our balance will get damaged as well. So cerebellum is important for equilibrium, head position, planned movement from the cerebellum. So just thinking and you want to pick up or touch this particular point, you need to have a good cerebellum. So you stretch out your finger, you come back and touch your nose. Stretch out your finger, come back and touch your nose, tip of the nose. So now you are planned, this finger, you plan to touch this finger to your nose. And that is the importance of the cerebellum. So if we do not have a good cerebellum, we will be touching nose. When we touch the nose, the finger will go into the mouth. The finger will go into the eye. So therefore, planned movement is input by the cerebellum. Of course, equilibrium as well. And new motor skills, motor memory. Let's say if you have done this, like if you have repaired the car engine once or twice, you have that hand memory and you are pretty easy to repair another car engine repair because you have the motor memory in your hand. Like, so the cerebellum will store that memory for you. So now look at the brain from the side, cauliflower shape, which is the cerebellum. In front of the cerebellum, we have the fourth ventricle. In front of the fourth ventricle, we have the pons, midbrain pons, medulla oblongata. And cerebellum is here, which is like a cauliflower shape. Look at that cerebellum. The cerebellum has got like a, little vermis, vermis here. So don't worry about the in detail structure of the cerebellum, but might be important, what does it do, this cerebellum does for us. So now, everything in our brain and the structures coming into the brain and coming out from the brain, they are all connected. So if you look at this diagram, this is the inner aspect. This is the medial aspect of the right cerebral hemisphere. You can see the corpus callosum here. Look at our eyes. As we know, eye is one of the special sense organ. The input from the eye will go through the third cranial nerve and we finally go to the reticular formation, reticular activating system, and keep the brain alert. Reticular activating system, and there is a lot. So you don't need to know everything here, but at least I want you to appreciate, like, just because of seeing it stimulate everything. You just all go to the frontal lobe, go to the parietal lobe, go to the occipital lobe, and go to the reticular activating system. Therefore, when you want to sleep, I think you should close your eyes. Otherwise, your visual stimulus will come into your brain, will go into your reticular activating system, and I don't think you will be able to sleep open eye. So nighttime or daytime, if you want to sleep, I think you better switch off your eyes. Otherwise, you will start seeing things and you will be thinking things from your frontal lobe. Your occipital lobe will be interpreting things. And all these information will be going to the reticular activation system and you will be awake. You won't be able to sleep with your open eyes. So whatever we say, we were talking about the cerebrum, right cerebrum and left cerebrum. A cerebrum is made of frontal lobe, parietal lobe, occipital lobe. And underneath the occipital lobe, we have the cerebellum. And we have the brainstem, which is colored with the green color. And once the brainstem go through the foramen magnum, it is called spinal cord. And we have in the middle here, diencephalon, which is made of thalamus, hypothalamus, and epithalamus. So that is our brain. So now I hope this diagram makes a little bit more meaningful. So don't forget the corpus callosum, which connects the right and left cerebral hemisphere. And underneath the corpus callosum, we have the lateral ventricle, third ventricle, and fourth ventricle. So thalamus, hypothalamus. Thalamus receive sensory information and transfer them to the brain. So let's say if you touch something, all these sensations will go to the thalamus first. Thalamus will filter everything. And then after that, it will go to the brain sensory cortex. So it is like a filtering area of all the sensation you take into your body. So your touch, your vision, and your cerebellum sensation, your feet. So all these, your smell, everything will go to the thalamus, and then the thalamus will filter which is what, and which part of the brain goes. So thalamus is acting as a transfer center. Hypothalamus, of course, hypothalamus because it is connected to the pituitary gland, which is involved in the neuroendocrine system. The thalamus in detail structure, which is not really important. This is the shape of the thalamus, which is like a flattened, like American football shape, thalamus. And hypothalamus is just above the pituitary gland, which is supraoptic nuclei and that sort of stuff. So they are here in the diencephalon and thalamus and hypothalamus. Primary sense area of the cerebral cortex, visual, auditory. So everything you put into your body, all the sensation, the thalamus have to pick it up and divide it and process and then send to the cerebral cortex, sensory cortex. Hypothalamus function is multiple. I believe you know that. It's involved in the control of the autonomic nervous system. We have to study autonomic nervous system. It's involved in the temperature regulation. So hypothalamus involved in temperature regulation. Hunger and thirst. So you hungry or you thirsty, it is also related to the hypothalamus. So let's say if somebody has damage to the hypothalamus, that person cannot control what to eat, what not to eat, how much to eat, how much to not eat. That is one of the problem with Kluver-Bucy syndrome. Kluver-Bucy syndrome, hypothalamus got damaged, that person will eat and eat and eat. So that is called hunger and thirst, which is included with the hypothalamus. Sleep, wake, of course, endocrine, emotional responses, motivational behaviors, formation of memory, everything, like nearly everything, all the inputs into your mind will go through the thalamus and hypothalamus. So epithalamus is just like a little pineal gland, which secrete melatonin, which we talk about that a brief in the endocrine system. Yeah, epithalamus. So this is the brain. Finally, life became a lot easier. Life became a lot easier from just the repetition. We have been repeating this diagram again and again, like frontal lobe at the forehead, occipital lobe in the occiput region. In between, we have the parietal lobe, and in the temporal region, we have temporal lobes, and just underneath the occipital lobe, we have the cerebellum. In front of the cerebellum, we have the brainstem, which is made of midbrain pons and medulla oblongata. This is the right side of the brain. It's your right, Sam. This is the right side of the brain. This is the left side of the brain. We call it right cerebral hemisphere, left cerebral hemisphere. Inside, we have a longitudinal fissure. That is a big split in between right and left brain, which is what we call longitudinal fissure. And the right brain and left brain is connected by the corpus callosum. Yeah, so corpus callosum. Now we have to split the portion between this temporal lobe and frontal lobe and parietal lobe. Let's split it, and we see the little here, the diencephalon region. So what is the dividing structures between the frontal lobe, parietal lobe, occipital lobe, and temporal lobe? Of course, as you can see here, brain is made of like bulge and valley and dip. A bulge here, the bulge and dip here, bulge and dip here. That is the brain, very convoluted, surface. Bulge out, go down, bulge out, go down. So this bulging point area is called gyrus, G-Y-R-U-S, gyrus. And this deepening of dividing area is called sulcus. Look at the sulcus. So sulcus is the going in. So this is the going in, is the sulcus, and bulging out is the gyrus. So the brain has got multiple dome-shaped gyrus and deep in gyrus. If the sulcus is too deep, that is what we call the fissure here. The fissure is the deep portion of the sulcus. So the going deep down is sulcus. If it is too deep, we call it fissure. And the bulging region is called gyrus. So we have a big, deep fissure here. If you look from the side, that is what we call central sulcus. So just in the mid-coronal plane around here, we have a big sulcus, which is what we call central sulcus. So anything in front of the central sulcus is called frontal lobe. Hey, look at that. Frontal lobe is here. Anything in front of the central sulcus is called frontal lobe. Anything behind the central sulcus, we call it parietal lobe. There, parietal lobe and occipital lobe is divided by the parieto-occipital sulcus here. So this area, gyrus, is called precentral gyrus because it is in front of the central sulcus, precentral gyrus, and this is called postcentral gyrus. So this is precentral gyrus is for the motor and postcentral gyrus is for the sensory cortex. So motor cortex is motor function located in the precentral gyrus and sensory function located in the postcentral gyrus. So just have a little look about these slides, you know, frontal lobe, parietal lobe, occipital lobe. What is their function? Frontal lobe for the movement, voluntary movement, planning, eye movement, speech, executive cognitive function, parietal lobe, general somatic sensation, and occipital lobe for vision, and that sort of stuff. I want you to have a look. Now it is interesting, frontal lobe, parietal lobe, occipital lobe, temporal lobe. It is just a little bit bigger diagram. And hey, temporal lobe, hearing, smell. Therefore, you know, if someone has got temporal lobe epilepsy, I believe you have heard about this, temporal lobe epilepsy, epileptic focus originating from the temporal lobe of the brain. So that's why, you know, these temporal lobe epilepsy, they are associated with smell. So the patient got peculiar smell in their nose before they got epileptic fits. The patient has like a little bit of hearing, like abnormal hearing in there, and then before they get the epileptic fits. And you know, insular taste sensation, sometimes they feel like some peculiar taste sensation in their mouth before they get the epileptic attack. So have a look. I want you to have a look these slides, so that which is important for what. And this is the motor representation. This is motor and sensory representation. Motor cortex is in the precentral gyrus, and sensory cortex is in the postcentral gyrus. And these are the representation. And I want you to look at the basal ganglia here now. So what we have to do, we have to get the brain in the transverse section, not the coronal section, not the sagittal section. The brain is being cut in the transverse section, and we are looking at that. This is the anterior, so frontal lobe. This is the posterior, so occipital lobe. This is the right hemisphere. This is the left hemisphere. This is the anterior horn of the left lateral ventricle. This is the anterior horn of the right lateral ventricle. This is the part of the posterior horn of the right lateral ventricle. This is the part of the posterior horn of the left lateral ventricle. And now we can see the, the third ventricle here. And you can see the nucleus here. Red nucleus here. And you can see the thalamus, which is just sitting close to the third ventricle. Third ventricle is related to the third ventricle. Basal ganglia. Basal ganglia is important in one way. because if you heard about Parkinsonism, so the disease which is called Parkinson disease, I believe you have heard of or you have seen this Parkinson disease. These patients, they have problem with the basal ganglia. So therefore, now these days they are talking about the depression might be related to the basal ganglia. The basal ganglia include caudate, putamen, and globus pallidus nuclei. So basal ganglia is a combination of caudate, putamen, and globus pallidus. It's not important, but it might give you some foundation for the next step. And the basal ganglia include job is motor function, cognitive function, and emotion. Therefore, if you look at the patient with Parkinson, their motor function is damaged because they are rigid. Their body is so rigid and they are shaky. They have like a pale rolling tremor. So the basal, try to remember basal ganglia with the Parkinsonism. That's the easy way to remember because they are more forgetful. Their cognitive function is not very good in those patients with, and finally, they tend to gradually go into dementia and emotion. So their emotion can be very labile, or they might be pretty, what do you call that, depressed. So try to relate basal ganglia with the Parkinsonism. I think that is the easiest way to remember basal ganglia. And basal ganglia include caudate, putamen, and globus pallidus. Like when we were medical students, we try to remember as Kapuji. Kapuji means caudate, putamen, and globus pallidus. So there are many different ways, you will have something in your mind, but try to relate to basal ganglia with the Parkinsonism, and that might remind you something. Okay, just a few more slides, and I won't disturb you too much. Look at that. This diagram is showing the basal ganglia. Kapuji, caudate nucleus. This is a small portion of the caudate nucleus. Putamen, look at the putamen, and globus pallidus. So caudate, putamen, and globus pallidus, which makes the basal ganglia, which is important for the motor movement, emotion, and the cognition. So the brainstem function, like the function of the cerebral cortex, I want you to have a look. Because if you understand it, I believe it will be more interesting. If you understand which is what, then the life become more interesting. So medulla oblongata, the jaw, function of the medulla oblongata, function of the pons, function of the brain. But in general, this is called brainstem. The brainstem, we have respiratory center, cardiac center, all the spinal tracts, like all the spinal tract coming from the brain going down, or anything coming from the spinal cord going to the brain, they are crossing in this area, and therefore, everything is important. And if you look at this green, what the brainstem, it is connected to the posterior cerebellum. So cerebellum and the brainstem, they are all connected, and therefore some of the cerebellum function will be influenced by the brainstem as well. So I want you to have a little look. And this is diencephalon, function of the thalamus, function of the hypothalamus. It is just like a final gathering, like summary of the jobs. The reticular formation, cerebellum's job. So it is really important. But hey, whatever it is, finally it comes to this. What is the brain and the spinal cord. The higher level thinking, brain, control the autonomic system, peripheral innervation through the cranial nerve, sense spinal cord is here. So now, hey, I'm just going to finish this, central nervous system. I hope you can sit here with me for like another 5-10 minutes. So this cerebral central nervous system, which is made of the brain stem, and then spinal cord. From the spinal cord, the motor will come out from the anterior, and sensory will go in from the posterior root. Combination of anterior and posterior root is called spinal nerve. Posterior in, anterior out. So this is the rootlets, anterior root, posterior root, and this is the spinal nerve. Here is what you call the posterior root ganglion, and all the nerve will go up to the brain, go to the thalamus. Okay, look at that. Just underneath the lateral ventricle, on the right and left, we have the thalamus here. All the sensation we have to relay in the thalamus. Let's say, if you look at that, you touch fire, this heat sensation will be carried along your peripheral nerve, because it is sensory, so it has to go from the posterior root and come here. There will be interneural, and then it will come out straight away with the motor root, and then go to the motor nerve, and you will pull your finger away from the fire. So it is so quick, it is so reflex. You do not think, touch the fire, pull your fingers back. That is reflex. So anything like, so that's why we say reflex means you don't think, you just do in response to what is coming in. So heat, pull it back. There is no thinking at all. So that is what we call the spinal reflex. You prick your finger and you pull your finger away from the prick. No thinking at all. That is the reflex function. But of course, some of the sensation fiber will go up to the brain, into the thalamus, and will go to the brain and remember as memory. And that memory tells us, hey, fire is hot. Fire is hot, and therefore we will not go and touch the fire again. So yes, you pull it back. That is the reflex. Heat, pull it back. That is reflex at the spinal cord level. It doesn't need to go to the brain. But for the long-term memory, this heat sensation will go to the brain and tell us, hey, this is look like fire, and that fire is hot. And that way it remain in our memory. So that is the spinal pathway, which is quick, and that is the cortical pathway, we just stay in our memory. And now what do? Fire, go, take your hands away from the fire, and you put your hands underneath the cold water. Again, like that is like, part of the memory involved, because yes, you are hot, and this memory, hey, you have to go underneath something cold, and you put underneath the water. So this is the voluntary response, which is coming from the cerebral cortex. Now we are getting to the end of the lecture very soon. And look at the cauda equina region. Look at the cauda. These are the spinal cord splitting into multiple nerve fibers, which are called the cauda equina. And this is the, C1 above the cervical 1 vertebra, C2 nerve root above the C2 vertebra, but we have only 7 vertebra, but we have 8 cervical nerve root, and therefore 8 cervical nerve root come underneath the cervical 7 vertebra, and since then thoracic 1 underneath the T1 vertebra, and then so on and on and on. And that is the way the spinal cord release the anterior and posterior root and then become the spinal nerve. And this is the little bit bigger diagram, which we have seen. And this is the spinal cord in the light microscope. Look at that central H shape, gray matter, and lighter the white matter. And you can see the central canal here. Look at the central canal. This is the last slide, guys. The central canal, in which is filled with very tiny, isn't it? Which is filled with the cerebrospinal fluid. And this is the anterior horn where our motor root come out. This is the posterior horn, which is the sensory root goes in. And this is the outer covering, dura mater, arachnoid mater, and pia mater. Pia mater will be very much stuck to the spinal cord. Dura mater is the outermost. In between, we will have arachnoid. Underneath the arachnoid, we have the subarachnoid space. And that's the end of this lecture, guys. I hope it is not too much. I mean, it is like, but I'm glad that we finished this in 2 days so that we can continue with the peripheral nervous system on Wednesday. Has anyone got any question?
Oh, I just have a quick question.
Yes, India.
With the, I don't know if I might have missed it or not, but I was thinking about it yesterday about the discussions.
Mm-hmm.
Is there a certain time frame when those need to be submitted, or because I've been doing them, but I wasn't sure if there, because it doesn't say a due date, and I was like, oh, I might have missed it on a lecture or something.
You know, usually I open up to about like 2-3 weeks, and let's say if you miss it, just email me and I will open it again. Yeah.
Oh, okay, gotcha.
So when I open it, I will open for everyone, like, you know, another 2-3 weeks, another 2-3 weeks.
Okay.
So these are the little points, so which is useful. Yeah, so do it.
Perfect. Thank you.
I follow you guys.
Okay. Thank you.
And hey, I think we will not do exam in November so that you guys have a little free time. And what do you call that? Thanksgiving. So yeah, no exam for November.
Yay.
Yay. Because we did August, September, October. So no exam for November. But there will be homeworks. Please do the homeworks. Yeah.
I may have missed something. Have there been discussions that have been due before now? Because I didn't do any.
The discussion, just let me know. I will open it again. But I just wonder, you know, at the end of the November, we will close all the discussions. What do you think? So that I can just like score everyone, so that we can give the final scores.
How many discussions are there?
I think we will have like every chapter, so maybe about 4, 5.
Okay, I need you to open them all because I didn't know they were there.
I will do that. I will do that, Michelle.
I as well missed number 1 and 2. I only did 3 and 4.
I can see
Thank
that.
you.
That's okay. You know, discussion is just like a, what do you call that? Extra bonus. So which I think is good. You know, you like when you read the discussion, you feel like you are not alone. Like everyone has problem. You know, they have all struggling with a few little things. So yes, good to see. So I will open them all today.
Are you going to give us like a study guide or something, or like a practice quiz for the final exam?
What I would do is I will open all the, what do you call, the homeworks. So that if, you know, someone like when you were doing the August homeworks, you are 7 or 8, then you do repeat it, and then you take 10, out of 10, so that all these homeworks, I will make final question from the question bank, which is from the homeworks.
Oh, okay, thank you.
Yeah, so I will not put anything new. So that just go through the homeworks again and again, like homeworks and the slides or the textbook. Yeah. I think the last day for the college is it 17? Let me check. 17 December. So which means, hey, we have to talk about final exam. When do you want to take it?
Would that be our last exam since we're not doing a November exam?
Yes.
Okay.
And I will not put many CNS. So that's for sure. Not many central nervous system questions.
I think as soon as possible, so we can get it over with and enjoy the holidays.
Yeah. So, the 17 is, so let's say, 17 is the last day for the college. So I think it is right. So if we open the exam on Friday, the 10th, and I will open it for like 5 days, so that before the school, like until 15 or 16, and during that time, I can just like finalize all the scores. What do you think?
Sounds good.
Yeah. So yeah, like 9 or 10, I will open it so that you have time. You have time because some students are busy, some students are away, some students just clashed with their work. So, and if you let everyone know, if you let everyone that who hasn't done the like August exam, September exam, October exam, then please let me know so that they can do the exam. I will open that for them. So because that takes a big chunk of the final score. Yeah. Okay, then we will meet on Wednesday morning, 10 o'clock. We will do peripheral nervous system.
Thank you, Professor.
Okay, bye-bye.
Thank you, Professor.
Bye-bye.